Good morning. My name is Eduardo Huesca. I'm here to provide you with an overview of OCAL's Migrant Farm Worker program. I work alongside a great team of people on this program. I'm the program's coordinator and outreach worker. So I don't have too much time, but I'm going to focus on discussing the context and service gap from which our program developed, the clinical aspect of the program, our prevention-based workshops and knowledge transfers, our work on identifying and developing effective resources useful to these workers, as well as to their employers, our collaborative work, highlighting one of our current collaborative projects, as well as future work we are directing towards other underserviced worker communities. I wanted to start with this picture found in the works of Janet McLaughlin, and which captures one of the first groups of Jamaican migrant farm workers arriving to the Niagara region under the Seasonal Agricultural Workers Program. Following this, in the mid-70s, the program started facilitating the hiring of workers from Mexico, as well as workers from additional countries in the Caribbean. Since then, these workers have continued to come in the thousands, joined by others under temporary foreign worker status from a variety of other countries, all of whom continue to play a vital role in the agricultural sector of Canada as well as of Ontario, with workers coming to work on small farms in numbers between 5 and 10 to those coming to work on very large farms in the hundreds. So this map shows a concentration of migrant farm workers throughout the province, with, as you can see, high numbers in the Niagara region, Norfolk, Haldimand County, as well as Essex County. Though our program is housed out of our Hamilton clinic, with some work initiated out of our Sarnia clinic, and more recently we have worked collaboratively with our Toronto clinic, our program tries to outreach to migrant farm worker communities in as many of these regions as our resources and current capacity allows. So we find ourselves driving across Ontario. Contextualizing our program, it was in short developed out of a recognition of the high hazard nature of agricultural work and of the particular experience and character of this worker population, of the precarious nature of their employment, of the strong intimidation held by many to raise concerns for fear of jeopardizing their worker status, of their limited access to additional supports, including primary health services, which was something we realized quite quickly, and as well as their disconnect from the occupational health and safety system.
In terms of that, the character of these workers, as part of a requisite for their participation under these programs, a lot of them have to have dependents, are coming from rural, low-income regions in their respective countries. They also have limited access to additional supports while they're here, including health services. So that was kind of, that disconnect was something that we also identified. And they really have a quite significant disconnect from the occupational health and safety system. Another recognition was that the majority of migrant farm workers we connected to had either not received key occupational health and safety information or training, or this information was provided in formats that were difficult for them to understand. So whether they weren't language appropriate or literacy appropriate or culturally appropriate. That largely the needs and experiences of these workers have been missing from industry-focused programs and strategies, and also from evaluations of the effectiveness of interventions occurring in the sector. So oftentimes this worker group was not really considered in a lot of strategies. So in terms of the roots of our program, work goes back to the 1990s with work with migrant workers in the Leamington area. In 2006, the OCAL Hamilton Clinic began dedicating more focused work on outreaching to more communities of migrant workers throughout the province. And in 2014, we received funding to establish this work as a stable program. So this is the list of the great team that I mentioned earlier. So we had Murray Lawrence and Michelle Tu, who provided fundamental work on this program before my time as well. With a lot of support from Curtis, that you have heard from today, our ergonomist, and a list of our physicians that have also staffed our migrant farm worker clinic. I should have really included the Toronto staff as well, who has, as of late, really helped us out in running clinics in their catchment as well. And so our program was really developed around our clinical consultations, or our mobile migrant farm worker clinics. So these consist of us connecting to migrant farm worker communities and support organizations that are already working with them in these areas. And alongside them and work with workers, we identify date, time, and location that's accessible to workers. And we basically arrive with our occupational health nurse and our physician and provide occupational health consultations for workers thinking that their health issues are related to work. So these clinics provide us with great opportunities to really learn about the health issues, the occupational health issues affecting these workers, to also understand the type of work that they're doing, their exposures. In some regions, we run clinics, maybe 2 clinics a season. In other regions, we really focus in and run clinics more steadily. We also have translators so that the service is provided in the language of workers as well. So this graph kind of identifies the main findings among the patients that we've seen in the migrant farm worker clinics from 2007 to 2014, with a total of 1,058 patients. So as you can see, the top 3 issues include MSK issues, musculoskeletal, which makes sense in terms of just the extensive lifting, stooping, bending of people. A lot of the workers we see are harvesters, and we also, another issue is dermal issues and eye health issues as well, eye irritations, an eye condition called pterygium, which we see a lot among migrant farm workers as well. Also worth noting, mental health issues are also on the rise or are becoming more visible among this population as well, with more organizations kind of tackling and looking at how to support. So an important part of our clinical activities is also focusing on connecting to local health services. So our clinics are not supposed to imply that we can provide long-term care for these workers. Obviously, it's not our role and it's way beyond our capacity. So it really becomes crucial to connect to local services so we can triage workers accordingly and connect them to local services for follow-up. This connection to local services has looked differently in different communities. But 2 examples that kind of demonstrate almost like our ideal situation has been our work with 2 community health centers, one in the Niagara region and one in the Simcoe region. So through great work of Michelle too, we supported a successful LIN funding request to establish 2 migrant farm worker specific clinics staffed by these community health centers in accessible locations to migrant farm workers. And in one of them, we provide a monthly occupational health focused clinic. So our physician and our nurse go and kind of provide that focus. And for the other, we are there as consultants, occupational health consultants, in case they need our support as well. So based on what we're finding clinically, we develop occupational health workshops, prevention-based workshops on the key issues that we're seeing, as well as other issues that migrant workers bring forward to us as well. So we run these workshops in community settings that are, again, accessible to migrant workers, and we also run them at the invitation of employers. We run them on farms. So these are some pictures of some farm workshops that we've given. So we really try to make sure that these workshops address kind of the needs of these workers and reflect kind of the feedback that they provide us as well, that we're using up-to-date ideas in terms of making them engaging, culturally appropriate. So these pictures are an example of an eye health workshop that we ran in Simcoe, Ontario, where we tried to use kind of the pin the eye drop on the eye, and we talked about safety glass use and proper fit and things like that. So it kind of was coupled with a barbecue that was going on at the same time. So it was quite a fun event, and we got really good feedback from workers as well. We also work a lot to identify, bring together, and develop tools, resources, info sheets that we feel are useful to these workers as well as their employers. So we distribute these en masse to workers through our attendance at health fairs, during our clinics, during our workshops. We also help distribute resources that have been developed by provincial partners. So for example, PMRA, Health Canada developed a poster around pesticide safety specifically for migrant workers, but just the nature of the program is not very outreach based, so we really took that poster around everywhere around the province, basically. We also, based on our direct work with migrant workers, we can also run kind of an evaluation of materials to really assess whether they're effective in communicating key information. So again, with PMRA, Michelle and some nursing students that she works with were able to evaluate and talk to some workers about what they understood of the PMRA poster, and we're going to be kind of preparing that to send to PMRA to kind of evaluate what they're doing. Yes. So early on, we also really identified a need to really get on